So what I just want to share with you is the current status of how do we put this into practice at the very least at my center, because apparently preeclampsia screening is not a standard of care just yet. But it's going to be very useful for you to know where are we at the moment and what are the strengths and weaknesses of all the parameters that we're using to predict the disease. Before I proceed, this is so American. As you can see, I'm so westernized. It's a disclosure of conflict of interest, because at our center we are participating with the PROGNOSIS trial, which is the sponsored trial by Roche Diagnostic to see the validation part of the split-1 and PRGL, which is biomarkers to predict the onset of preeclampsia on a short-term basis. And I'm also working with Thermo Fisher to develop the first trimester screening panel for the preeclampsia, but that's going to be in the first trimester, so it's different objective from the Roche Diagnostic. But this presentation is totally non-commercially supported, and the content is individually prepared. Just so you know that the preeclampsia, I think, is a big problem here. It's a big problem anywhere because we can barely prevent it from happening. And this is a news, headline from Thailand like a few years ago, that one of the famous actresses in Thailand, she gave birth to the baby at like 25 weeks, and she suffered from severe preeclampsia, and she broke a vessel in the brain, and she went into paralysis, and the whole thing followed. I mean, she had HELLP syndrome and all that kind of thing. So that brought this disease, back into the public attention again. So these are the serious complications of preeclampsia. Just 2 months ago, we just published a review, on the complication of preeclampsia on the anesthesiology perspective in the Journal of Maternal Fetal Neonatal Medicine, and we based our review on the electronic medical record, based on 700 severe preeclamptic patients in the past 10 years at our center. And surprisingly, I mean, the morbidity of the mother, decreased a lot. The morbidity of the infant, on the other way around, is quite stable in the past 10 years. But the thing is, our threshold for delivering any women, with severe preeclampsia is getting lower and lower, when time goes by, because we know that our NICU is getting better and better as well. So, preeclamptic patient, you wait too long, the patient can develop consequences like abruption. The patient can lose the uterus. It can bleed in the womb, in the belly of the patient. So this is the thing that actually is the goal of prediction of preeclampsia. So we're not happy just to be able to predict that, okay, the disease really happened and we are right. We're not happy just that. So at the end of the day, any preeclamptic screening strategies that you're going to be using has to be proven to reduce this kind of morbidity, and then it's going to be, then you're going to say to yourself that, okay, you are doing the right thing. All right, you're not just predicting disease because you can do it, but you can predict disease because you know that at the end of the day, it can reduce maternal and neonatal morbidity. And I'm not sure what criteria you're using in Pakistan, but at my center we changed the criteria, the diagnostic criteria for preeclampsia instead of just new onset of proteinuria hypertension. The patient now can either have proteinuria or not. They can have hypertension and any evidence of endothelial damages from blood tests, as the platelet are less than 100,000, creatinine doubles, your liver function increase, and those kind of things. We call it non-proteinuria preeclampsia. So it means that we are paying more attention at the endothelial damages because of the disease. And that is how the uterine artery Doppler will come into play. So at the very end of the disease, you see endothelial dysfunction for the whole body. It will follow by cardiovascular dysfunction and systemic inflammation. So there are 2 strategies actually. The early prediction is aiming at, like in the first trimester, that you can give the mother aspirin. And by giving a high-risk mother aspirin, it can reduce the chance of developing early onset preeclampsia down to 50%. That's not great. I mean, only 50%, but it's better than doing nothing. So and it means that for the early prediction, you have to screen every single pregnant woman, and that came the alternative strategy because in some countries you cannot afford to do uterine Doppler to every single woman, leave alone the nuchal translucency measurement, right? Especially in countries where the government doesn't really subsidize the prenatal screening of any kind. So the alternative strategy is you just pick up only a selective group of women. So you do the selective screening. We call it the short-term prediction for women who have a higher risk of having preeclampsia already. So we put them into the screening strategy to see how likely they really are going to be developing preeclampsia, so that we can give them more closer observation, dexamethasone, and maybe refer them to the facility that have the tertiary, the level 3 NICU. And this is an added benefit of being able to screen, so that you can screen the woman that that this one is at a higher risk. You can allocate them into a research protocol in terms of trying to find the effective preventative measure of preeclampsia. I think Pakistan is using this guideline, right, for the NICE guidelines. Right now, I think most people in the world giving aspirin to pregnant women based on these guidelines. This guideline based on the history alone. So if you see any women with hypertension from previous pregnancy, or they have chronic hypertension, chronic kidney disease, autoimmune disease, or diabetes, you give the aspirin at 12 to 16 weeks. And the dosage of aspirin is between 75 to 81 milligrams that we call baby aspirin. And so the preparation varies from one country to the other. In Thailand, baby aspirin means 81 milligrams. In Europe, baby aspirin means 75 milligrams. So what is baby aspirin here? 75? 81? 75. Okay, so you're more European. So we don't have 75, we have 81 milligrams. So we just keep what we have. So for the moderate risk, you need 2 risk factors in order to give the woman aspirin. However, the NICE guidelines, you do not have to invest any money to screen women based on NICE guidelines. So it doesn't cost the woman anything, but the detection rate is very poor. You can pick out only 30% of women who will develop preeclampsia. So it means that 70% of women will not gain any benefit from this screening strategy at all. But the plus side is that it doesn't cost a dime. So when you talk about the early prediction, you have to screen everyone. And right now, the Kipros group is working on it in the PE ASPRE trial. They're using multivariate algorithm using the clinical history, uterine artery Doppler, and the biochemical markers. For the short-term prediction, you choose only women with prior risk, like if they are borderline hypertensive, if they are diabetic, if the baby is having growth restriction, and they choose to have the plus serum and serum plasma PLGL, and that can boost the detection rate up to 95% instead of using the history alone. And actually, the data from these 2 groups right now are coming out. And I'm going to show you the preliminary data just so that you can make up your mind of which screening strategy you want to implement in your own setting. And now we're talking about the population, all right? We're not talking about, and fetal therapy is so individualized. But for preeclampsia, you're planning for the policy. Which policy will be the best for your institute or for your city or for your country? You're going to go for the universal screening, or you're going to go for the selective screening, or you don't screen at all. So just let the disease happen, and we will just follow the disease and treat it. I mean, there's no right or wrong on this. It depends on the cost-benefit analysis of each and every country. So fact number 1, you want to screen it early in the first trimester, or you want to see if the women develop any risk during the course of pregnancy, and then you pick them up and screen them to make sure that you will allocate the resource more effectively. One fact is that the earlier you screen the woman, the chance that you will miss is higher. The screening has to be based on the fact that the woman have to have the systemic organ damages which will not occur later on in pregnancy. So, but if you detect the woman too late, then the disease is almost about to develop. You cannot really prevent it from happening. The disease will happen, but you can prevent the consequences of the diseases like the abruption, like the fetal hypoxia, by closer observation. So for preeclampsia, if you want to screen, these are the criteria based on the WHO advice that the screening has to, any screening strategy you're going to be implementing into your population has to fit into this model. Unfortunately, preeclampsia screening doesn't really fit into that model very well because it has a very, first of all, the biomarker is quite expensive. Ultrasound, I'm not sure how expensive ultrasound for the uterine Doppler here, but it could be pricey, especially in Europe. But again, treating women with early onset preeclampsia in Europe is costly as well. So it depends on which country you're talking about. And at the end of the day, you're not talking about predicting the disease, how successful you are, but you have to be able to reduce this mortality. So this is a real goal. Fact number 2, screening for preeclampsia is different from screening for fetal Down syndrome. Any one of you measure NT on a routine basis whenever you do the scan for the first trimester? Can I see some hands, please? So you do, okay, all right. So when you do NT, the nucleotranslucency, it means that you know that if the baby is or is not having Down syndrome, the Down syndrome is there. It's totally a different concept from screening for preeclampsia because preeclampsia isn't there yet at the time of screening. So you are screening for something that isn't there yet, so there is no confirmation. For if the NT is thick, if the biochemical marker is suggestive for Down syndrome, you do the CVS or amniocentesis, you get the answer right away. For preeclampsia, you predict, okay, you have a 30% chance of developing preeclampsia, and that's it. You wait for it to happen. You put that anxiety onto that woman's mind, and she'll be bearing that, and that word of yours will be haunting her for the rest of the pregnancy. That, okay, if I have preeclampsia, what would happen? I may seize, my blood vessel might break in the brain, I may have paralysis, my baby might have hypoxia, the baby will even die or suffer from cerebral palsy. And you have no way to prevent it from happening. Aspirin works only 50%. So that is a downside of having a universal screening. But the upside is that somebody said that, okay, 50% prevention, but by aspirin is an upside of it. So this is the thing that you have to keep in mind. Universal screening, it consists of clinical history. According to the NICD guideline, you have to measure the blood pressure in the first trimester. You have to check the urine protein in the first trimester as well. You combine it with uterine artery Doppler. And you use serum biomarker, which is now PAM-A and PLGL. So this biomarker is automated platform. Blood pressure now is automated as well. Urine protein is lipstick. Clinical history is very easy, it's a checkbox. The thing that will play an important role in the accuracy of preeclampsia screening is here. I don't think that people are measuring uterine artery Doppler on a daily basis. It took a while for people to know how to measure NT correctly. And if you measure the uterine artery Doppler in a wrong way, you put the positivity index into the algorithm, you get the you put the garbage in. What you will get back is a pure garbage. So it means nothing. So the adoption of the preeclampsia screening using uterine artery Doppler will be even more challenging. If you dissect the strength, for instance, for the history, the old age, nulliparity, previous history, familial history, the strength of the history is quite low. And actually, the majority of preeclamptic patients doesn't really have a suggestive history at all. So that's another challenge. It's very easy to take the history, but it has a very low prediction for the preeclampsia. If you look at the maternal history alone, you can, like I said before, you can pick up early onset preeclampsia in only 30%. 70% will not be picked up by history taking. But if you combine it, by the uterine Doppler, and you combine it with the serum biomarker, you can pick up early onset preeclampsia up to 90%, which is very good, very good. But again, you have to factor that the uterine artery Doppler have to be trained. What is the difference between early onset preeclampsia and late onset preeclampsia? The early onset disease, first of all, the baby, if you decide to deliver the baby, then the baby may suffer actually from iatrogenic prematurity, and the cerebral palsy might be related to the degree of prematurity that you decide to deliver the babies. All right. And the early onset preeclampsia, you cannot just sit on it. We know that the disease is very aggressive. It can turn into HELLP syndrome within hours. But luckily, it is less frequent. Compared to late onset preeclampsia, it's more prevalent. I think that most of the cases you see labor ward are late onset diseases, which you can sit on it for another 2 days and nothing will happen. All right. This table is quite fuzzy, but I deduce it from quite a few publications. For early onset preeclampsia, it's a minority of the cases, unlike late onset, it's a majority of the cases. You can predict early onset disease very effectively by combination of the history, ultrasound, and biomarkers, and you can pick up over 90% of the cases using this combinative algorithm. But if you can reduce maternal and perinatal morbidities by using this screening algorithm, it remains to be proven by Nicolaides trial, which should be out, the result should be out within 2 years. For the late onset diseases, again, because disease happens very late, is less aggressive, any prediction strategies that you're using has a very poor predictive value. But since it carries a very low morbidity to the mother, it may not really be the center of attention that we really want to screen. But the thing that I highlighted here, by history alone, if your patient have a prior history of giving birth prematurely because of preeclampsia, the chance that she will develop preeclampsia again in this pregnancy depends heavily upon the gestational age at delivery. If previous pregnancy was affected by preeclampsia that required delivery at less than 28 weeks, there is an almost 50% chance you will have it again. So for that actress that you just already put on at the beginning of my presentation, if she asks, okay, she had to deliver at 25 weeks for this pregnancy. If she wants to get pregnant again, what is the likelihood that she will have preeclampsia and will end up with the same result? This is the number. If that preeclampsia happened between 29 and 32 weeks, the chance is about 1/3. And if that preeclampsia is quite late onset, then the chance is getting lower and lower. So this number is quite useful and is very settled that you have to give them aspirin. So for this highlighted column, I think it's most useful and practical information for you to use with your patient. If they have preeclampsia before, ask them, did it require premature delivery and at what gestational weight? And you will give them the risk right away, and you will give them aspirin between 12 to 16 weeks to prevent it from happening. Now, we talk about uterine Doppler. Actually, uterine Doppler for the high pulsatility index and pre-diastolic notching, it has a very high sensitivity and specificity. Actually, it's the strongest parameters in the algorithm. And that's why I'm saying that the big problem of screening every woman is that how do you think you can obtain a good quality uterine artery Doppler for every sonographer? Again, this is one that, because at my center we are doing the preeclampsia screening, but it's on the research basis. This is a normal uterine artery Doppler waveform. You see the systolic and diastolic cycle, and there's no notching between the systole and diastole. This is a normal uterine artery Doppler waveform. And just so you know how crazy it is, it was the 16th of May, which is on Monday, 10 o'clock at night until in my clinic. And that's how crazy it is. So if you want to screen everyone, prepare for this. All right, so you're gonna be spending like late hours, in your clinic doing uterine Doppler over and over and over again. It's a nightmare. So this is the pre-diastolic notching. I'm not drawing the line myself. All right, the computer draws it, so you see the dip, between the systole and diastole. We call it pre-diastolic notching, which indicates increased resistance at the end of the uterine artery. All right, so where is the uterine artery? Uterine artery is the one that crosses the iliac artery in a perpendicular in a perpendicular axis. So this is the iliac artery, the arterial vein, and this is the uterine artery that cross it like perpendicularly. So the uterine artery indicate how bad or how good the placental bed is. If there is a atherosclerosis at the end of the at the tail end of the uterine artery, it means that the remodeling is not happening as it should have been. The trophoblast and implant on that uterus will get into the process ischemia, maybe like in the late second trimester, and ischemic trophoblast will release a huge amount of vasoactive mediator that constrict the blood vessels. So the patient will have elevated blood pressure because of constriction of blood vessel, but the intravascular volume is down. That is basic pathophysiology preeclampsia. For the NT, everyone knows that getting certification is easy. Maintaining it is another story, because when you screen for your institute, you screen like a mass screening. It's very difficult to get every sonographer to be kind of at the same standard all the time. I'm not saying that Fetal Medicine Foundation is the best. I'm not saying that at all. I'm just saying that there should be a third party evaluating me. Not that because I am Tom, I have to be right about everything. No, I have my bad days. Some days, my NT is like wrong, like so wrong. I didn't sleep last night. I cannot keep up with the standard. So there has to be some kind of standardization going on in the institute. Otherwise, again, you put the garbage in, you get the garbage out, and bad screening is worse than no screening at all. Trust me. I mean, if you have a bad screening, you're missing the high-risk women, and you are treating the low-risk women with aspirin, which is not a low-risk medication. Women can bleed. So if we just leave the uterine treatment out because you do not want to spend hours in the clinic until midnight like me, okay, just go for some easier thing. Go for just a history taking and the serum biomarkers. That strategy works only for the second trimester screening. All right, so if you take out the uterine Doppler, it means that you have to do the selective screening, and it's going to be in the trimester, and the aspirin doesn't work. So now you screen because you don't want, it's not because you want to prevent it from happening, but you want to pick it up like early enough in order to prevent the morbidities resulting from the disease. And these are the examples of all the biomarkers that has been explored for this job. And it boils down to that PRGF is the best, period. If you have to choose just one single markers of all the 30 markers that have been investigated, it has to be PRGF. We published over 10 years ago with Richard Levine that why the biomarkers can help us predicting the onset of the disease. And we show that the cell lysis in the placenta is increased only a few weeks prior to the onset of preeclampsia. So the same pattern going on, with the same pattern can be observed in ASPRE-1, but actually the decline of the PRGF is much better indicative of the onset of the disease. So now that we just put the biomarkers into the spotlight and we just forget about the uterine Doppler, it's quite easy to adopt. It's simple, it's safe, but what PRGF you are talking about? If you don't know, I want you to know right now, there are at least 4 commercial manufacturers that provide the automated platform to measure PRGF, because everybody knows that it's the strongest biomarker to predict preeclampsia. There are PRGF1, there are PRGF2, there are free PRGF, and the total PRGF. And each and every company offers different kinds of PRGF measurement. Again, if you are running your own hospital, or you're going to be an expert and you're going to be building your own hospital and you want to choose a platform, make sure that you know what you're getting yourself into. I'm not suggesting which company is better than the others. What I'm saying is that we are using PRGF on the basis of multiple of the median. So you want to use any platform, make sure that you stick with it, and you have your own MOM, like here. I think I'm going to pass it because I can study it because it's going to be too boring. This is we use Roche diagnostic, but not because Roche is better than the others. Because Roche approaches first and it offers some benefit that, and it doesn't really matter which company we use, as long as we have a very good monitoring system that our multiple the median is consistent. All right, so this is the number that we use. Why do we need this number? Can we just download it from the website? And there are publications talking about the MOM of the PLGF and S1. No, you cannot. You have to have your own multiple the median, because Valoran published in 2010. Oguchi the same year published in 2010. The nomogram of the FLIT1 and PLGF based on the Lexis automated platform. The FLIT1 in Asian population, the data of Oguchi and our data match like perfectly. S-FLIT1 in Oriental Asian, again, Thai, Japanese, South Asia like India, Pakistan may not be applicable for this, but our S-FLIT1 is lower than that of the Caucasian. And our PLGF is much higher than that of the Caucasian. So if you want to use the PLGF as a prediction in your own population, there's nowhere else. You have to have your nomogram in order to calculate. And the first publication on the PROGNOSIS trial was out just earlier this year, and it shows that if the FLIT1 and PLGF ratio is over 35, then if it's under 35, then it is quite effective in ruling out the possibility of having preeclampsia. So you do not have to worry about that woman. So that is the main sentence from PROGNOSIS trial. All right. For the detail, you can just read from the New England Journal, and it's free download, so you can read it like at will. So now with all that information, I think I have simplified that. Whenever I give a talk on preeclampsia, usually it's about cracking numbers. It's very boring. It's very boring. So let's bring it to perspective. You're running a hospital. You want to put a blood test in the menu. What would be the basic test that a woman needs? You add preeclampsia screening into your menu. For the first trimester, you have to include uterine Doppler. For the second trimester, you can exclude uterine Doppler, but you have to add serum marker, which is PAP1 and PLGF. And it will increase the cost of pregnancy care quite a lot. The treatment offer, I mentioned that already, that the only proven treatment that can prevent preeclampsia from happening is aspirin, which can prevent it only about 50%, not that much. So I would say if you predict it only in high risk group, the chance you will be able to give the woman aspirin is none. So we don't talk about aspirin anymore. And just so you know that in clinically high risk group, the bad outcome are actually not related to preeclampsia. For instance, if they have a prior history of IUGR, IUGR is one of the prior risk of preeclampsia. It means that the blood vessel is very poor. So they are having an increased risk of preeclampsia, IUGR, preterm birth, and unexplained death. 4 major things that can happen. So it's not really specific to preeclampsia, all right? And last thing about the prediction is that if you can detect that S-FLIT1, which is another biomarker, a vasoactive meter, is increased, there is an investigational treatment that's ongoing in Europe and in Boston that you can do the selective plasmapheresis. You can filter out the S-FLIT1 molecule out, and you can prolong the pregnancy for at least 2 weeks. And between 24 to 32 weeks, the neonatal survival increased 2% every day that the baby remains in the womb. So this treatment is temporizing treatment, it's still investigational, but it can benefit from screening strategy that if that woman has preeclampsia related to increased S-FLIT1, then you can use plasmapheresis to prolong the pregnancy and to reduce the neonatal mortality. So that goes back to our publications, we were just released, that actually the morbidity of the neonate hasn't been down at all in the past decade. partially because we have much less tolerance to preeclampsia. We tend to deliver the baby more and more prematurely in order to save the mother. But it comes at the cost of the neonatal morbidities. So this temporizing treatment might be benefited to a selective group of women with elevation of SFAT1. In conclusion, if you want, this is the pros and cons. If you want to take a picture of any slide, these are the two last slides that you want to take pictures. The first trimester universal screening is good because you screen everyone, and you know that most preeclamptic women do not really have any clinical prior risk. Actually, 70% of them don't have any prior risk. So just by history taking alone would be helpful. But the bad thing that I would emphasize is that how can you standardize the uterine artery Doppler measurement? You can do it on an individual basis, of course, because you are good. But if you are controlling the whole unit, that's not going to be an easy job. If you want to switch to the short-term prediction, you go for the second trimester. Okay, you give aspirin. You don't give them aspirin because that will prevent preeclampsia only 50%. I want to use my resource very effectively. The bad thing is that, the good thing is that you don't have to worry about standardization of the uterine artery Doppler measurement. But the bad thing is that you will tend to deliver the baby prematurely anyway. Because this strategy doesn't prolong the pregnancy, unlike aspirin. And you may reduce the maternal mortality, but you are not really reducing the neonatal morbidity at all. What would be the conclusion? The conclusion, I believe, it will be different. Depends on the population you are talking about. If you're talking about the European population, I think the first trimester universal screening will fly. Because the government subsidizes everything. In the US, the universal screening will fly because the insurance will cover everything that can reduce the maternal morbidity. But in limited resources country, which is the majority of the world anyway, you have to think about it. Because if you use the universal screening, of course you can cover everyone, but the problem how you can standardize it and how you can justify the use of the resource. If you use the second trimester screening, again, you will miss a portion of women. You reduce maternal morbidity, yes, but you do not really reduce the neonatal mortality. So that is my conclusion.